All right, everyone. Hello, everyone, and thanks again for joining us today, and welcome to the 9th episode of Ewings U. I'm Piero Spada, and once again, I'll be your host for today. For those of you that don't know me, I'm also one of the co-founders of Little Warrior Foundation and dad to 12-year-old little warrior Lucy. Today, we are excited to be heading back to Levine's Children to hear from Dr. Aaron Trovillion about the clinical aspects of the BCC's Information Precision Medicine program. And for those of you that don't know this webinar is a follow-up to our first ever Ewings U episode with Dr. Scholler. So if you missed that, it might be worthwhile to go back and view some of that background information. And that's on littlewarrior.org. Just search for the Ewings U tab. This is out of order. Do we have Dr. Trovillion? No, okay. So briefly, a bit about Dr. Trovillion. She received her medical degree at Rutgers University and completed her residency and fellowship at the University of California. Currently, she is board certified MD and Peds Hem/Onc, and she specializes in treating children with sarcomas. She is also an assistant professor at Atrium Health Levine Children's Cancer and Blood Disorders, a facility of the Carolinas Medical Center, as well as Isabella Santos Foundation Rare and Solid Tumor Program. And equally important as her credentials, she is quoted as saying, "It is amazing to be involved in a field that is making advances so quickly to improve the care and outcomes for our patients." Furthermore, she is humbled to walk beside her patients and their families on this difficult journey. The energy and the strength of her patients inspire her on a daily basis. And as a true testament to your care, Dr. Trovillion, you have all 5-star reviews under your profile. As one patient family put it, "Love her to death. She's very caring and a lovable person." Thank you so much for everything, Dr. Trovillion, the entire staff and team members. She is an outstanding doctor. So suffice it to say, very high praise for you, and we thank you for your excellent patient care, Dr. Trovillion. And when she is not working, she enjoys spending her time with her husband and 2 amazing children, hiking in the woods, riding bikes, and just playing in the dirt. Who doesn't like playing in the dirt? She and her husband enjoy traveling, and her favorite country visited so far is New Zealand. She also enjoys riding her stationary bike and listening to audiobooks. But before we start things off with Dr. Trovillion, I just want to let everybody know and remind you all that Ewings U is a webinar and podcast production of the Little Warrior Foundation. We are a national childhood cancer foundation with a laser focus on finding a complete and permanent cure to Ewing sarcoma. We were founded in April of 2020 and have granted out $1.4 million in high potential therapies for increasing survivorship and decreasing toxicity. And this program that we're discussing today is a prime example of the grants we've made thus far. For the past 2 years, we've supported this program. And in order for us at Little Warrior Foundation to make programs like this a reality, we rely on the support of the little and big warrior community. So we really appreciate all of your support to continue our mission so that we can continue to bulldoze our way towards a solution and continue this vital work for kids with Ewing sarcoma. Lastly, we are also honored to have another special surprise guest with us, the Wheelers. We are so grateful to have Jen and Jeremy Wheeler join us in this discussion, as they are mom and dad to now 11-year-old Bryn, who's currently in the middle of a 4-year battle with Ewings. Bryn is currently being treated with precision medicine under Dr. Trovillion. So this discussion should offer a peek on how this program works, both from the physician standpoint, as well as the patient perspective too. We are so grateful to have the Wheelers here with us and thank them for their willingness, their courage, their strength, and openness to share their personal experiences with this program. So thank you guys for being here. I'm going to hand it off to my co-host, Emily, to introduce herself and touch on a couple of housekeeping items, and then we'll get the webinar going. Thank you.
Great. Hello, I'm Emily McFadden, one of the other co-founders of Little Warrior Foundation. Just a few housekeeping items. I wanted to let you know that this session is being recorded, as are all of our Ewings U. They'll be available on the Little Warrior website under our blog in our Ewings U section following this webinar. So we'll get you that recording. Please use the Q&A button on the bottom of your Zoom to ask questions throughout the webinar. We will leave plenty of time for questions for Dr. Trovillion and the Wheelers as well. I normally say we cannot discuss specific cases, but today we are going to talk a little bit about Bryn and her experience. So with that, I will pass it over to Dr. Trovillion to get us started.
Well, thank you all for having me today. We were just reminiscing before we came on this, and it's been about a year since the Wheelers first contacted me. So we've come a long way in a year, and I hope you can all learn something from my presentation today. So I will share my slides. Let's make sure that you guys can see them. Does that look good?
Perfect.
Perfect.
Yep.
So as they said, I am one of the pediatric oncologists here at Atrium Health Levine Children's in Charlotte, North Carolina. I joined here about 2.5 years ago, going on 3 years, right in the middle of the pandemic. I had been in California for 9 years, but I'm from the East Coast originally and wanted to get back closer to family with 2 little ones. And I'm going to tell a little bit of how I got here in this job, but looking but not looking for a job, and a solid tumor position was advertised for here in Charlotte. And solid tumor is always what I have loved about pediatric oncology. A solid tumor patient is who stole my heart in residency when I was not going to be an oncologist and I had my sights set on something else. So it has always been near and dear to my heart. And I jumped on it. And when I talked to the physicians here and our leaders, it was very clear that they were focused on making things better and giving patients opportunities that they might not be able to find elsewhere in the country. And our mission here in Charlotte is to not have to have any patient in Charlotte leave Charlotte, and to be able to offer them any treatment available to them around the country here in Charlotte. And I think each day we're a little bit closer to that reality. And now I've been able to be a part of sharing this with people around the country. So we're going to talk a little bit about that now. So I couldn't do any of this without obviously Beat Childhood Cancer. Dr. Scholler is the founder of the Beat Childhood Cancer Consortium. They do amazing work in neuroblastoma, and now we are expanding the reaches to sarcoma, which is fantastic. So there are 2 focuses in Beat Childhood Cancer. One is obviously clinical trials. There have been many clinical trials related to neuroblastoma, but we also have a mission and a goal for precision medicine. So to understand each individual patient's tumor, not just lumping them all into one category of Ewing sarcoma, but really diving deep and saying, how does each case differ? What makes it unique? Why do some patients relapse and others do not? Why do some patients respond fantastically to chemo and others do not? So we want to take it a step further and really understand the biology of each patient's tumor, and hopefully dictate treatment based on this. So we have a program called the Information Program. And again, it's just that. We want to get more information about each childhood cancer and each childhood tumor and learn more along the way. So our vision is that all children with cancer have that each child who walks through our door here, and as many across the country as we can, that they have complete genomic sequencing of their tumor. We believe so strongly in this that, as we'll talk about later, there's no charge to families for this. Our foundation believes so much in it that there's not a cost to patients. We want every child across the country to have access to this information so that it can be utilized by their treating oncologist. So when is this supposed to be offered? We offer it at all opportunities. So anytime there is a opportunity to get tissue, we want to test it, because we also believe that tumors change with time and tumors change with treatment. There is an evolution of tumors from the start to the end. So we like to see how that changes, and should we be changing treatment along the way. So we offer this testing to patients at diagnosis, and then at any point they have a surgery either to remove their tumor, or in unfortunate cases where there is a relapse, at the time of relapse. So the more information we collect, the more we'll know, and the more we know how to use this information. So as much as we use this clinically and we try to make recommendations, a lot of it is still research-based and a lot of it is still being utilized. So as I'll talk about in a little bit, we are using this to make personalized medicine decisions, but we also are capturing this in a database. And the more patients we are able to sequence, the more we will learn about Ewing sarcoma as a whole. And by combining that genomic data, we hope to then be able to ask clinical questions in the lab, as well as for clinical trials, which we're actually already doing here in the Beat Childhood Cancer Foundation laboratory here in Charlotte. So already this data that we're able to collect and compile is leading to clinical questions that we can now study in the lab in real time. So this is just a outline of what we do. So we collect information clinically, patient treatment, what were their responses, we sequence their tumors. What's different from our sequencing than a lot of other sequencing is that we not only report the DNA changes, but we're also analyzing the RNA. And we're analyzing the DNA and RNA of up to 20,000 genes. So a lot of companies throughout the country offer genetic testing of tumors, but if you look in the fine print, they're only looking at a certain number of genes. So anywhere from 300 genes can be tested up to 1,000 genes, but they select those genes. We are looking at all of the genes within the tumor and all of the RNA. Do we find things at times that potentially we don't know what that means yet? Yes, but the more patients we sequence, the hope is that we learn more about these changes and is there an implication for treatment. After we get that data, and it's a lot of data, we rely heavily on our bioinformatics team to analyze the DNA, to analyze the RNA, and them along with us as clinicians do a deep dive into the literature. What is out there on these genes? Is there anything out there on these genes? And what can we synthesize from this data? We then take all this data and we host a molecular tumor board where we discuss it with oncologists, pharmacists, bioinformaticians from across the country, and report data back to patients like the Wheelers. Step further, in our local patients, we also simultaneously are trying to, if the tumor is here in Charlotte, we take that tumor and we bring it right to our lab, right as it comes out of the patient, to try to grow them in the lab so that we have real live patient samples that we can study in real time. We're not going to focus on that as much in today's discussion, but that is another side of the coin that we are looking at and creating mouse models as we speak. This is just another depiction of how this happens. The clinical side is what we're going to focus most on today. So the sequencing, a tumor board, can we recommend any treatments? And then how do the patients do? So we call these remote second opinions. We began offering this in June of 2022 formally. In 2022, we completed 20 RSOs. As you can see, most of them were sarcomas, most of them Ewings. So 12 were Ewings, 4 were rhabdomyosarcoma, and a couple of neuroblastoma. Out of those 29 follow-ups were done, meaning that the families proceeded with genetic testing of the tumor. We were actually successful in testing the tumor. We can touch on that a little bit later, why sometimes that's not always possible. And then we had molecular tumor boards and then follow-ups with the family where we presented our recommendations. In 2023 so far, we've completed 6, a little bit more diverse in diagnoses this year, but off to a great start already. So this is just a pyramid and how this works. I think I'm going to pause here so that we can talk about the remote second opinions, why we do it, and have the Wheelers share a little bit about how they found us, the process of contacting us, and how they found the opinion to go, or the process at least.
Hi, everybody. Can you hear us? Okay, like thumbs up. Thanks, Piero. Hi, my name is Jeremy. This is my wife, Jen. As mentioned earlier, we have a 11-year-old daughter, Bryn. She was diagnosed with Ewing sarcoma in December of 2018. So a little over 4 years now. In this battle, multiple relapses after the initial diagnosis in December. And after, I think it was after maybe after 3 lines of, went through the traditional first 2 phases of chemo, radiation, surgery, and then tried some medication in the third round, which didn't end up working. And then that's how we came across, and we were just searching really high and low for what could we do from, from more precision medicine standpoint. We had been reading and, seeing a little bit out there on just makes sense to treat the actual tumor of the individual child versus a generic approach. So I think it was through a Facebook page Jen was on with other cancer moms, right?
Mhm.
That Jen found and heard about what was going on at Levine with the Beat Childhood Cancer Consortium. And so we reached out and contacted, I think we just, reached out to Dr. Scholler, Dr. Trovillion directly, got their contact information, and immediately they responded, which was really nice to see, right? I know they're very busy. And so really we found this through word of mouth. And beyond, we got sent some paperwork. It was real easy. It was, as Dr. Trovillion mentioned earlier, of course, all the expenses you incur fighting cancer is, a lot of it's through the roof, right? And so when we first heard that, to do a lot of this was no charge, we were like, wow, that's pretty amazing. So that was, thankful to all the donors out there, Little Warrior and the Information Project that's able to make this happen. So, and then we got some paperwork we got to fill out, relatively easy. And then we had Bryn's she had a couple surgeries over the years, and her tumor's been preserved. So our local, we're here in Southern California, our local children's hospital sent the tumor over to Levine, to the laboratory that's where the analysis is done, which was, again, a pretty, it takes a little bit of coordination, but a pretty painless process. And so I would say the onboarding was a pretty easy process from there. So anything more specific, I guess, there, Dr. Trovillion, you want me to touch on, or Piero?
I think that was pretty good. Like, how receptive was your local team to this program, and what did they know about it? I guess, can you touch on that a little bit?
Yeah, when we started looking at it, they didn't really know much about it. But the options that were given to us were, as far as trials and stuff, did not look super appealing. And kind of got to a point where they were like, here's a few options, but really just enjoy your time with her. So
we heard that on a couple of occasions, actually. Yeah.
With how much vitality she had still, that wasn't really an option for us, is to pick one of these subpar trials and go forward and deplete her quality of life pretty quickly. So I think being with our same oncologist for the last 4 years, she was willing to look into this possible option. I think she even spoke with Dr. Trovillion at one point. And they have been continuing to collaborate with us and with Dr. Trovillion.
That's amazing. I think
Yeah,
Dr.
to
Trovillion,
answer,
Go ahead.
answer a little bit. So I get personal emails asking about this program, or we have a actual email address. So I pulled up what you're seeing now is our information flyer, and I can give this to you, Pero, to share. We have a program coordinator, but we also have what we call a destination care inbox, where our team is constantly getting emails, whether it be from around the country or around the world, and they sort of handle the intake. So if you reach out to me, it's fine. I then pass you on to our intake team. Like we said, it's pretty minimal information that is needed to start this process. So obviously a release of information is needed from the parents or the adult with the Ewing sarcoma, or any sarcoma for that matter. It's not just Ewing's. And a brief medical summary with treatments that have happened. That's all we need to start the process. Then we very quickly after that set up a call to just discuss what the program offers, what the testing includes. On that same call, if you choose to participate, we go over consents, because obviously there has to be permission for exchange of tissue and things. And then our team here at Levine does all of the hard work. So they contact the hospital to get the tissue. It gets sent right to the team that is doing the genetic testing. That usually takes about a week or so, depending on how responsive the hospital is. And then the testing itself takes about 3 weeks. We very quickly know if there's not a lot of tissue, because obviously tissue is really important on all of this. And sometimes biopsies or samples, there's not enough, or it's been used for other types of testing. And that does happen. And we quickly let the family know that we weren't able to run the genetic testing. That is pretty rare. You can get a lot of information even from a very small piece of tissue. So even if it's a tiny piece, we still really recommend trying. It doesn't hurt to try. And so then once that happens, they run the analysis. It takes a couple of weeks. Once I get that analysis, my team and the bioinformatician team, they then look at all of the data in a higher level and the RNA data, which we'll talk about in a little bit. And then after that, we have a follow-up call with the family. I then share all of that information with the family. So they get a summary letter, which I'll show you in a little bit, about the findings and the recommendations from the molecular tumor board. They also get the genetic reports from the company, and that is free to be shared with your treating oncologist. I encourage it, and I also encourage them, if they have questions, to reach out to me. The Wheelers primary oncologist did reach out to me. We were able to talk about things. They asked their questions, and it was a very collaborative approach, which is what we want out of all this. We don't want primary oncologists to think that I'm dictating their care. I just want to see it as an addition. I want to try to add things to what's already being done. I want the patient to stay in their home base and stay around, their support network, but try to offer as much help as I can from a distance. So that's sort of how the process goes.
Okay.
Is there any questions you want me to address, Piero, from the chat or anything before I move on to what sort of the mock tumor board looks like?
No, I guess we can put a link to this one pager in the chat section so everyone has it. But then secondarily, one comment on tissue samples. If I'm not mistaken, there's a qualitative aspect to it too, right? It can't be paraffin embedded in order to do the deep dive. Is that correct?
So, not necessarily.
Okay. All right.
So obviously fresh tissue is always, it hasn't been touched, it hasn't been processed, but we can actually do the testing a lot of times on paraffin embedded.
Okay.
Samples that have been decalcified are
There it is.
sometimes harder to obtain genetic information from, but we will still attempt it. So really, whatever is available, we can try to get information out of. But good question.
Thank you.
All right, you can see my slide, right? Okay. So a little bit about the process. So once a family agrees and consents to the testing, we go through all that procurement I just talked about, and it goes off to testing. We do whole exome and whole transcriptome. So that essentially means we're looking at the DNA, what makes the cell a cell, and then the RNA, which is essentially, I like to describe it as the messengers of the cell. It are the proteins that are telling what pathways to be active in a cell, what pathways are told to be quiet in a cell. And we think, to some extent, these pathways that are over or under expressed or active are likely what is driving a tumor cell to survive. It's likely what is having that tumor cell survive after we've already treated it or have it come back. So that is sort of what we focus on, and that's why it's a deeper dive than a lot of other genetic testing. So then we take that information, we go to a molecular tumor board. As you can see, this program is rapidly growing. 10 patients were presented in 2021, 44 in 2022, and there's already been multiple tumor boards this year. We do have tumor boards every week. So we're presenting a lot of patient, a lot of data. This is just a nice little depiction of how we go through this. So we go through their history, we go through their testing. We have a lot of different experts on the call that talk about the DNA changes that we're seeing, what it means from a geneticist point of view. We talk about the RNA expression and what drugs may be available. We do a dive into the literature. Has this been used at all in the type of cancer we're looking at, specifically here, Ewing sarcoma? And then is there any data on these drugs? Are they safe in kids? Is there data to support combining it with other chemotherapy? And we rely heavily on our pharmacists for that. From that, we create sort of a plan. I blew this up on the next slide, but essentially, does the tumor have any findings? Is there a drug that affects that target? Yes or no? Can we use that drug? Yes or no? And what makes us choose drugs? So I'm going to switch to, with the permission of the Wheelers, and show what we did. First, we did it back in March of last year. I actually looked, but I'm going to pull up the one from July. So essentially, each patient has unique IDs. Again, I don't share patients' names. This is all identified based on the ID they're created when they have their genetic testing. Fortunately, with Bryn, we were able to sequence 4 specimens. Not fortunately that we had to have all those relapses, but we did see changes over time in her tumor, and that helped us choose what medications to recommend as part of her precision medicine therapy. So we go through the timeline of their medical history. We look at any recent imaging that they may have. In this discussion of last July, we had already made some previous recommendations based on some findings we found, and they had actually started some of that. And she wasn't on it for very long before she had her next relapse. So we kind of took that to say, did this work? Did this not work? But we ultimately decided she hadn't been on them long enough for us to really say, had that affected her relapse or not. But we had made multiple recommendations as to treatment strategies, and then gave an update. She had done 2 cycles of one of the inhibitors, 1 more cycle of another, and then unfortunately had her relapse in June of last year. We talk about any current medications the patient's on, so that's always an important piece of information, mostly for our pharmacists, because we want to make sure any recommendations we are making are done as safely as we can. So if there are drug interactions, our pharmacist wants to look at that. We don't want to make any recommendations for things that may harm a patient. We also do this so that we can make monitoring recommendations. For instance, are you on a medicine that maybe we need to check an EKG? So knowing the patient's current medications is really important. So we look through the genetic results. We have our genetic team walk through this. Then we look at the RNA results. This is a fun little plot. I'll talk you through it real quick. So all of these are genes within a cell that are over or underactive. This is not all of them by any means. It's just a small subset. So anything under 0 means that that pathway or gene is being underexpressed. And anything on the right side of the screen is pathways and genes that are being overexpressed. We consider normal to be anywhere between -2 and +2. So in this section here, we actually don't get very excited. So we really are focusing on the areas where there's more overexpression compared to a normal cell. And this was a sample from 2020. And then as you can see, that bar plot shifts a lot with Bryn's next relapse. So there is changes that are occurring within the tumor when tumors come back. And that's called evolution of the tumor and can make us make different treatment recommendations. So based on this, we look at these top pathways and then we say, are there drugs that can target these pathways? Turns out there's a lot of drugs that can target the pathways that were overexpressed in Bryn's tumor. And that led us to make some recommendations. I think I have the letter pulled up. I do. So we then generate a letter where I essentially talk you through it in English about the genes that are found, the RNA that is found, because even for oncologist, it's sometimes difficult to walk through those genetic reports and have it make sense. I look up any clinical trials that may be available to the patient, where they're located, what these changes mean, if we even know what they mean, and that's just based on literature that's available. And then I walk through the targets and what they're targeting, as well as combinations that can be given. I didn't put it in this letter, but I think I sent it to them separately in an email, is our pharmacist will make recommendations based on dosing. So we even send that along so that treating oncologists have an idea of what dosing and what would be safe to give to a patient. And that is what a molecular tumor board sort of looks like. I didn't know if Jeremy and Jen, you wanted to comment on sort of that feedback that you got and how you found that information helpful.
Yeah, for sure. Yeah. Thanks for going over that. Yeah, I mean, what Dr. Trovillion said is we actually got something that was easy to understand, right? It's nice to see the graph format, right? The overexpressions, underexpressions, and the drugs that target, right? Those those pathways. And so that's something we had never seen. I mean, we had like some of the higher level, I think the DNA reports done, a lot of you maybe listening have had some of these testing done like at Foundation One and other places like that. I don't think correct me if I'm wrong, Dr. Trovillion, but I don't think they go down to the RNA level like the lab you used did, right? And so, is that right?
No, the RNA is sometimes reported what they test for, but we take a deeper dive based on a lot of normal samples. So we rely on normal samples and a database of normal samples to compare these tumor samples to. So everything we are deriving is mathematically based, but it's based on hundreds of normal tissue samples. And how does that tumor compare to a normal tissue sample? And that's how we get those numbers.
Got it. Okay. So yeah, it was nice to see all the different options, right? There was chemotherapy, there's traditional, I call traditional IV chemotherapy options. There was oral, options, right? Both oral chemo and also inhibitors as well that affect the pathways that were overexpressed or underexpressed. So our goal when reviewing the report was let's keep Bryn at home versus, in the hospital with IV to the extent we could. And we have been able to accomplish that for the last 18 months, 2 years, probably, using oral, we use metronomic dosing chemotherapy along with some of these inhibitors that were listed in Bryn's report that are targeting these pathways. The other thing we liked about it was, as we've researched and we've learned from Dr. Trovillion and others, you really got to take a multi-drug approach to see, for your chances to succeed, right? Usually monotherapy has not been successful in the past with Ewings and other cancers. So we've layered on multiple drugs, inhibitors, even curcumin, as you saw on that list that was flashed on the screen a few minutes ago, layering things like that into her into her treatment. Anything to add there on that before talking about obstacles?
I think that was most of it. I mean, from June when she had her brain surgery, and then after brain surgery, we found some more spots throughout her body of disease. We've pretty quickly, within a month, started this new treatment. And within a month of being on, again, with the layering of drugs, we usually start with 1 or 2 at a time and then slowly add in the other ones. But within a month, there was significant improvement on her PET scan. And that led us to August, getting a good, she had her disease had regressed. And then November as well, her disease has, regressed. We went about 7 to 8 months of disease regression up until we hit a little roadblock in February of some progression. But again, we're tweaking things a little bit, taking out a couple meds and introducing a couple new ones.
Yeah. Yeah, there's testing we're doing also, like, for example, like blood biopsies that help us tell, we think are helping us, this is outside of Levine, but help us tell the effectiveness of some of these drugs that we're using. So to Jen's point, we made some tweaks right now with the assistance with Dr. Trovillion and taking a look, because cancer evolves, as Dr. Trovillion mentioned earlier, and so it can figure out new pathways to use. So we're now targeting additional pathways, right? That might have become more active in this last relapse. And so it's nice to be able to, on the fly, make these, make some educated decisions on the treatment to take, and it's treatment pathways to take. And what's been really impactful to us is just we've had the last 2 years, Bryn's been at home, right? She had that brain surgery episode back in the middle of last summer, but outside of that, she's been home at school, riding her horse, playing volleyball. So being able to live this very active lifestyle, not being held back,
And feeling good.
and feeling good. In fact, feeling really good. So, and it's, I think it's this because we're taking this in large part, we're taking this precision medicine approach.
It's probably one of our biggest motivators
Yeah.
in pursuing this type of treatment.
Yeah. So one more comment, just looking at my notes here, and some of the obstacles you might be wondering what obstacles you might face in some of this. And so, insurance has been, in the end, it's worked out from an insurance standpoint, because these drugs that are prescribed aren't necessarily,
Specific
for Ewings, right? I think the term is off-label. It's using these drugs off-label. So the insurance approval process has been a little bit painful, but thankfully our local primary oncologists and team have been very proactive in helping us get these drugs approved. There's multiple ways. You can go through insurance, you can go outside of insurance, compassionate care, right use. We paid out of pocket in some instances where we wanted to get the drugs in hand immediately. So there's, multiple avenues to go down, but that has been, in terms of obstacles, that's probably been, one of the main ones. It's just been the insurance process, but and then talking to Dr. Trovillion and her other patients, it seems like it always tends to work out. Ultimately, people can get it.
Yeah, we fortunately have a fantastic group of people here that we start the process immediately with getting, insurance companies. A lot of times it's denied. We go through appeals. Sometimes we do need to go through patient assistance and get drug for free through the drug company, but we've been able to get drug every time we've wanted it. So it might take a little legwork, but with the push, you can get it.
Yep.
Thanks, guys. That's been super helpful. I don't know, Dr. Trovillion, do you have anything else to add? Wheelers, I guess one question for you guys is, did Bryn at all have any say in what she wanted to do and from a treatment standpoint, and how did that factor into your ultimate decision and what you guys decided to do?
For her, not being stuck in the hospital, anything that interferes with what she wants to do on her, in her daily life. So to stay out of the hospital, out of doing IV treatment, she'll always pick that.
Yeah, we go over the options with her in plain English and say, hey, she understands the disease and it's there, and progression or regression, we're very open with her, and always maintaining a positive attitude if we're going to beat this, right? And so here's the options, Brent. Here's what we're looking at. And here's what's going to keep us out of the hospital. Here's what's most effective, and so on and so forth. So yeah, she's involved and has become more so as the years go on, and she can understand more.
I actually think one of the calls I had with Jen and Jeremy, Jen was with Bryn at riding her horse.
Oh yeah,
and was able to show me her riding her horse. So
Wow.
even in the short time I've known them, she's continued to do the things she loves, which is also one of our goals.
Yeah.
Amazing. Is there anything else before we delve into the Q&A section? We got quite a few questions here, so which is good which should make for a healthy discussion.
I don't have to go through these slides, but just so you know, the biology part of things, the research part of things is us trying to compile this data into a data set and say, query it. I think this is numbers sort of to date of how many patients we've enrolled on this biology study. It's over 200 in less than 2 years. So we're able to, any genetic testing that they've had, compile it and ask questions. We are using some of this data now to ask some questions within the lab on Ewing sarcoma. And it's formulated our hypotheses in the lab with the hope that potentially we lead to a clinical trial in the next year or so with augmenting therapy based on these results. So the more patients we're able to sequence, the more data we have and the more we hopefully can get closer to a cure.
Awesome. All right, why don't we pull down the slides and we'll jump into the Q&A session. Emmy, I think you probably have the first leadoff question.
Yeah, we have a few questions from people asking about the upper age limit of the information project.
Yeah, so
Big
there's
warriors.
no age limit. None at all. There's no minimum, there's no maximum. We just want to help as many patients as we can. So adults, peds, I will talk to everyone. I have seen or have talked to some patients, young 20s, but I don't care what age you are. If I can help you, I will try.
Awesome.
And then another real simple kind of follow-on logistics question. I think on the one pager for the information project, it references a $500 RSO charge. Can you just clarify the kind of what's free and what would be covered?
Yes, so there is a $500 remote second opinion charge, and that is for all the time that our team spends on looking through these cases and going through them. That does not go directly to me. We do have some financial assistance for that too, if patients and families aren't able to pay that. But what is free is the testing, the genetic testing, which can be thousands of dollars, especially if your insurance company does not cover it. So we always first bill to your insurance. If they cover it, fantastic. If they do not, say you have 4 samples, such as Bryn did, you will not be charged for all 4 samples. If your insurance company does not pay for it, the Beat Childhood Cancer Foundation pays for it directly. So you will never get a bill for any of the genetic testing. But there is the $500 fee just for all of the time and effort that our team spends. But again, there are ways around that as well.
Okay, thanks for that. There's some questions here surrounding who the third party is doing the sequencing, and would you utilize other whole exome sequencing from other competitors like Boston Gene, Foundation Medicine? And then secondarily, outside of the tumor biopsy, can you utilize blood, like liquid biopsy or other tissue, to do the analysis that you need to do?
Yeah, so we are currently partnered with Caris molecular testing. So that is a whole side of Beat Childhood Cancer that I am not part of, but there are contracts in place with Caris molecular testing where we get all of the data that they run. So therefore, I cannot take whole exome sequencing that was performed at another facility and run it through our pipeline. Although I will ask, I have no problem asking if we can take that raw data, if it's provided to us, and run it through our RNA pathways and see if we make any hits. I'm happy to ask those questions. I have no problem asking that to see if we can use other platforms and see how we can work around that. And then liquid biopsies. So some families have used liquid biopsies and have shared that data with me. Unfortunately, there's usually not enough cellular components in the blood to get all of the data we need. Circulating tumor DNA is certainly going to be the wave of the future, and a lot of companies are trying to master that. But for the amount of genetic material that is needed, there's often not enough just in circulating blood.
Okay. Thank you for
And
that.
just to add to that real quick, we get blood biopsies done, and what it did was corroborated the information that we got from Dr. Trovillion. So there were certain drugs in the blood biopsy that were recommended to treat, the circulating tumor cells, and in our case, it was, I don't know if it was lucky or not, but it would corroborate the information, so it was helpful in our case.
Thanks for that. Emmy, next question.
Muted. So There is a great question. I'm going to try to pack it down into, if this information is so important to capture at diagnosis, how do we do a better job of capturing this information or creating awareness about this type of sequencing to people who may not even know they have cancer or Ewing sarcoma? When they go in for that initial biopsy, how do we spread the word that people should be asking for this?
It's a great question. So we, at Beat Childhood Cancer, we are trying to open the biology study at all of our sites across the country. I believe we have it open at almost 10 sites now, with over 10 sites in the process of opening it. And the hope is that at least at those sites, we start being able to capture all of these patients at diagnosis before they even have their biopsy, before we even know if it's Ewing sarcoma. So for example, here in Charlotte, anytime I see a new patient with any type of solid tumor, before they go to the OR for a biopsy, I consent to the biology study, knowing if it is a cancer, we now have that saved tissue that we can do extra testing on. So the hope is that we at least are opening those at the Beat Childhood Cancer sites, so that more tissue can get to us in a more streamlined process. Outside of that, I think it's unfortunate we're gonna have to rely on word of mouth. We're even talking about, if you're not being treated at a Beat Childhood Cancer site, but there is one in close proximity, can we work with your home institution to get that tumor to the Beat Childhood Cancer site? We are doing virtual consenting now for the biology study. So that also helps reach wherever. You don't have to be in Charlotte. So the hope is that it'll be far reaching in the coming year or so that it's open to and available to more patients without them needing to ask, is this available? It'll just be presented to them as, here is an option for you.
Awesome. I'm trying to just break down and distill this next question. It has to do with like the genetic RNA expression levels and finding druggable mutations, and this person wanting to understand that process a little bit more. Like, how broad of a net do you throw at targeting a specific overexpressed mutation? Like, what does that process look like a little bit?
Yeah, so essentially it's all in comparison to normal tissue. So we rely on our bioinformaticians to essentially create algorithms that compare the RNA of the tumor to the hundreds of normal RNA. And then you get a score that essentially says, how different is this RNA in the tumor compared to the normal sample? And the more different it is, we presume that means that it's potentially driving that cancer more. So we focus on the genes or the pathways that are the most different from normal samples. Kind of saying, without actually growing the tumor in the lab and testing each individual tumor, that's sort of the best way we can compare to a normal cell, is to compare the genes. So it's all based on mathematic algorithms comparing to normal samples, and we get scores that say you're the same as normal, you're overexpressed compared to normal. And again, I can't guarantee that it's going to help what drives it, but in Bryn's case, as they mentioned with the liquid biopsy, it correlated with what we found in the RNA. And then they actually started one of those medications, and in her subsequent liquid biopsies, that went away. And that's the hope as we grow this, is that if liquid is available, we can see these changes happen in real time and see that our medications are making a difference.
Awesome. And then I guess a follow-up to that is that oftentimes you're using or recommending FDA-approved drugs in an off-label capacity. So the data set is really pulling from other cancer types to say, in this cancer solid tumor type, it was efficacious against XYZ, whatever the druggable mutation is. So therefore we think it could be plausibly used in Ewing sarcoma. Is that correct?
Yeah, and we're pulling from a lot of adult data, obviously, as a lot of these drugs haven't been studied extensively in pediatrics. So we pull our data from a lot of adults in sarcoma work. We pull it from non-sarcoma. So if you look in the literature, for example, one of the drugs that Bryn was on It's a JAK1 inhibitor. I'll be perfectly honest, we've found a lot of JAK1 overexpression in almost every Ewing sarcoma tumor we've tested, yet there's no data on JAK1 inhibition in Ewing sarcoma if you search the literature. So you kind of have to extrapolate a little bit and say, well, it's here, should we try it? Or is that one of the questions we should ask in a lab? Does it actually work on the cellular level, or is this just a pathway that happens to be overexpressed? Dosing can come from a lot of different disease processes. So a lot of these medications are used in leukemias or lymphomas. So we extrapolate dosing. Some we know you can't combine with certain sort of standard of care relapsed Ewing's regimens. So it's just not safe to combine the two. So our pharmacists help a lot in making sure the drugs are safe and that the combinations are safe and that monitoring is, we usually send out monitoring if there's monitoring beyond, for example, lipids need to be checked. We'll let the family know that. So a lot of different people pull from a lot of different places to make the recommendations.
Okay, thanks. Emmy?
You know, I have to sift through all like the fan mail coming in for all you guys.
A lot.
The gratitude for both the Wheelers and Dr. Trovillion is pouring through the Q&A section. So do have a question here about the information project and your approach to collaboration. I know BCC is its consortium itself is very collaborative. How do you guys think about data sharing with other researchers, institutions?
We're very much open to that. We are currently doing that with another institution who's very big in Ewing sarcoma research, sharing the molecular data between the two. We share cell lines. We've been able, from this project, we have, I believe, 17 Ewing sarcoma cell lines now in our lab. So we've been able to share cell lines with other labs so that they can do work on Ewing sarcoma. We're very open to that back and forth collaboration because we can't be the only ones working on it. So if other people want to use it and, you know, join forces, then we are more than happy to do that.
All right, we got time for a couple more questions here. This is talking about combination targeted therapy. What's been the approach thus far, like chemotherapy plus one targeted therapy? And would you ever combine multiple, let's say, off-label drugs for a given patient, a given kid?
So,
don't want to get you in trouble here, but
no. I do not think that one drug is the answer or will ever be the answer. I'm very weary of monotherapy in either trying to prevent relapse or treat a relapse, because it has already figured out a way to bypass the combination chemo we've already given it. So we often make recommendations that are at least 2 drugs, whether that's in combination with the patient is already on or 2 novel agents that we combine. When we do that, we look at overlapping toxicities. So we try to choose drugs that do not have overlapping toxicities. And personally here in Charlotte, because most of the patients I've had these calls with, the Wheelers have been the most forthcoming in sharing with me their journey afterwards, which I always encourage the families to do. I always want to know how patients are doing. And the Wheelers have been honestly the most forthcoming and have shared with me. I think every time she gets a scan, they're sending me the results and keeping me in the loop, which I greatly appreciate. And so I don't know how many of these patients, other than Bryn, I know a couple other have tried some of the targeted agents we've recommended, but I use it on a lot of patients here. So I can think right now, at least 5 patients right now that I'm using this data to give them targeted therapies after I've gotten them into remission. And as long as you're monitoring them for toxicities, as long as they're tolerating them okay, then, and they're staying in remission, we continue it. I've given patients up to a year of oral chemos with keeping them in remission. So it's very patient specific. You have to be able to monitor them. And that's where we rely heavily on the other oncologists, is are you willing to monitor these things? And are you willing to make sure that there's not unwanted toxicities? Because we don't want any toxicities.
In our personal experience, yeah, we multiple drugs, we oral chemo plus oral inhibitors most recently.
Mhm.
And then there's been, I think one time in the last
Just in September.
September,
Yeah.
in September, we had to adjust one of the
Mhm.
oral chemos a little bit because it did cause, was it neutropenia in Bren potentially?
Yeah,
I think,
neutropenia. She needed blood transfusions. And
yeah, which was a quick 24 hours or 36 hours in the hospital, and we were out. But you just this is kind of new territory, right? So that's going to be expected. But our doctors locally are closely monitoring this, her levels in her blood, and we made the adjustments necessary.
Thanks for that, Wheelers. Emmy, do you have anything else to ask, or should we wrap things up? How's the Q&A looking?
They keep rolling in. I love this one, but why don't more hospitals join the Beat Childhood Cancer Consortium?
That's a great question. Is Abby still on here?
Right.
Abby's quietly in the background.
I saw Sarah on too.
I don't even know how many sites we have. We have a lot of sites now. We have international sites. It's a lot of work actually to join a consortium. It's a lot of work for hospitals to join consortiums, open up clinical trials. There's a cost. So there's a lot of barriers. I think if every hospital could be part of every consortium, why wouldn't they? But there's obviously the backside and the business side of things. And do they have the staff to man those clinical trials and things? So we are far reaching. The BCC has grown tremendously in the 10 plus. Abby's texting me. She can't come off mute. Otherwise I wouldn't leave you hanging. Thanks, Abby. Appreciate you. Maybe you can type it in the chat or the Q&A. But there's just a lot of behind the scenes. I agree. Why not be part of something that can help patients all across the country? But I think that's what we're trying to do. And I think that's what most of pediatric cancer tries to do is we all try to be very collaborative. We all try to share our data. We want patients, no matter where they are in the country, to get what they have. I always tell patients, even my local patients here, I would never be too proud to tell you to go somewhere else if I thought that was going to be the best thing for you and for your child or you as the patient. I think as pediatric oncologists, we should always be looking for what's the best options and offering that to our patients, even if that means traveling or if that means asking some questions and getting it at your hospital. So I think pediatric cancer is a lot more collaborative than possibly adults at times. And, we all just want what's best for our patients.
We talked a little bit about this before the webinar began, but this project is so important to know about before you need it. And so we encourage everyone, print out that one sheet or share it with people who are in whatever phase of their fight. It's important. Share it with your oncologists so that they know that this is out here too, and just really help us spread the word. It makes a big difference to know about this before you need it.
Agreed.
All right. Any parting thoughts by Dr. Trovillion or the Wheelers before we wrap things up? It's been a lively discussion.
No, I just thank you for this opportunity to share what we're doing. I hope we hear from families, from other institutions, and whoever we can help. But no, I just appreciate your time.
Thanks for the opportunity to present here, and I think my parting thought is don't take no for an answer. When you're dealing with your local or primary oncologist, never take no for an answer, and just keep searching and digging. And we're thankful we ran into Information Project Dr. Trovillion, right? And so that's my parting thought.
And thank you for that, Wheelers. That's well said. We love you guys, and please know we'll continue to hold you guys and Bren in our thoughts and prayers. And please know that by sharing your personal story with us today, you are giving others hope in the now. And I even saw in the comments, you guys put your personal email address down there for others to reach out to you to talk about this. So thank you for being here. Dr. Trovillion, this was a fascinating discussion. Thank you for leading and for everything that you do for kids that are battling Ewing sarcoma, and for not accepting the status quo, because clearly we can and need to do better for these kids, and you guys are actually practicing that right now. So thank you guys for all of this. We appreciate it. And for all of our viewers today, thank you guys for joining us as well. We'll see you back here again in April, specifically April 18th at 2 p.m. Eastern, as we're heading to the University of Pittsburgh, specifically to talk to Dr. Kelly Bailey, who is the head of COG's Ewing Sarcoma Drug Task Force. So you can find more information on our Ewing's U email list, as well as our website, simply littlewarrior.org, and search Ewing's U tab. You can follow us on Instagram and Facebook. And as always, we will post about our next speaker that way. So we have to do the traditional Little Warrior sign off. I don't know, Dr. Trovillion's already smiling. I think the Wheelers know it too. It's just simply a 1, 2, 3 swords up, and we'll bring this thing to a close. But thanks again, everybody, for being here. So on the count of 3, 1, 2, 3.
Swords up.
Swords up, everybody. We'll see you next time. Thanks for being here.